we proceed for that.
So should we begin with the program? Should we begin with the program, sir?
Yes, yes, yes.
Yes, sir. A very good and healthy morning to all of you. Today we have virtually gathered here on the IMA platform under the able guidance of our President, Dr. Sanjay Devkale, who is a pathologist by profession and most humble and is always ready to help. I welcome you, sir. I also take this
Thank you, madam.
opportunity to welcome our office bearers, Secretary Dr. Sachin Gathe, Vice President Shehnaz Ma'am, Manjusha Giri, Joint Secretary Manisha Rathi, Ashish Khandelwal, and I also welcome all the faculties, Dr. Ashish Satav, Dr. Shrikant Ambalkar, Dr. Yogeshwar Kalkonde, and our experts of today's program, Dr. Jaydeshmukh sir, Dr. Anurag Bahekar. Now I invite our President sir for his welcome address.
Thank you, Ragini madam. Good morning to all. There is some problem in getting the link, so I am extremely sorry for the delay. Respected Divisional Commissioner sir, Dr. Sanjeev Kumar, who is the chief guest for today's function, and this is basically his idea. Dignitaries in the audience and learned and humble down to our expert speakers. COVID-19 pandemic, a biggest challenge in the life of doctors we are facing. We all, including the administration, fighting very, very hard against the most dreadful disease we ever face in our life. Never learned anything about COVID-19 in undergraduate and postgraduate. Everything is totally new for the administration people, our own people, and also for the doctor fraternity. With very limited knowledge, the virus is just playing with us. But I feel very proud that under the able captainship, stewardship of our respected Divisional Commissioner, sir, Dr. Sanjeev Kumar, our doctors, paramedical staff are trying their best to sail the ship of the COVID-19 safely to reach the shore. I am confident we will reach the shore safely, but for that we have to sacrifice the life of a lot of our best sellers. Just a minute, I had call from Divisional Commissioner, sir. Let me. Hello. Informs sacrifice life of some of our best sellers. Am I audible?
Yes, sir, we can hear you.
I'm confident that we will reach the shore safely, but for that we have to sacrifice life of some of our best sellers in the form of doctor, paramedical staffs, and some of the administrative people. I pay homage to all of those 800 doctors who sacrificed their life for this battle against COVID-19. The topic for today's CME chosen, COVID-19, journey from urban to rural areas. Urban like UK, where every medical facilities are available at ease, but opposite to that, rural areas like Mirghat or the Gadchiroli search, where nothing is available. We all are eager to listen how Dr. Ashish, Dr. Yogesh, saving the life of patients without CT scan, limited blood investigation, limited oxygen supply, non-availability of the so-called the most powerful weapon of this fight is remdesivir. And there are a lot of things they are not getting, but in spite of that, they are fighting this fight. The faculty has, but these facilities are easily available at the UK. So we are having at the another spectrum, that is Dr. Ambalkar, who will be speaking how they are managing this people in the UK. So I finish this welcome I also welcome Dr. Archana Kothari Madam, who is our observer for today's CME. And I also thank DigiShield for helping us out. I finish this by saying, don't say that the Indian health system has collapsed. It hasn't. It is highly real, resilient. No doubt it is overwhelmed, but no hospital has shut down. No doctors has retreated from the front line. They are fighting COVID-19 missile with sticks and still holding the fort. And I am very confident that with the support of all doctors and paramedical staff, we will win this battle against the COVID. Thank you very much. Over to Ragini Madam. Over to Ragini Madam.
Sir, I think she has left. I can't see her on the screen. We can.
Yes, she got disconnected.
She got disconnected.
So we can start with the first topic.
Shehnaz madam bhi nahi hai. We can start with our first topic.
Just a minute. I am getting call from Ragini. Just a minute.
Okay.
Yeah, we can have the first topic.
Our first speaker is Dr. Ashish Satav sir. He is from Melghat Dharani, well-known personality. He is Padma Shri and working hard in tribal area. So I request Satav sir to give his presentation.
Hello. Good morning.
Hello.
Good morning,
Yes,
Ashish.
Good morning. Good morning. Am I audible?
Yes, sir.
Yeah.
Yeah. Very good morning to all senior faculties, my few guides, teachers, and friends. Actually, due to a lot of serious patients in ICU, I could not prepare very well for this topic, but I'll try at my best. You cannot start screen share while other participant is sharing. There is message. Hello. Hello.
Sir,
Yes, sir,
your
try
screen
again
is
now.
visible.
Is it
Try
visible?
again.
Okay. So
So screen
as
is not visible. Please try again
Not
now.
visible.
not visible. Just a minute. Is it visible now?
Yes, it is.
Okay.
Please take that to full screen.
Yeah. So good morning again. I'm Dr. Ashish Sato, working in tribal area of Melghat since last 23 years on behalf of Mahan Trust. My topic is COVID-19 in tribal area of India. Thanks to Sanjay Bhau for inviting me for this important meeting. Tribal areas are hilly, difficult to access forest areas situated in the outskirts of the states mostly. Melghat is situated in the northeast part of Maharashtra. It is around 300 kilometers from Mumbai. Mahan stands for meditation, addiction, health, aids, and nutrition. We are catering services to 320 tribal villages of Melghat and 100 tribal villages of Madhya Pradesh. Our base hospital is at Karmagram in a forest. COVID-19 in tribal area background. Tribal area of India constitutes around 8.9% of total population. There are around 104 million tribal people and 705 tribes. COVID is spreading now like a disaster in tribal areas. As per survey by IIT Delhi of around 117 tribal districts, 3% of the tribal population is infected. It is in way back 6 months before. The population of Melghat is around 3 lakh, spread over 4,000 square kilometer, and the average population village density is 940 per person per village. People are thinking COVID cannot enter to tribal area, but there are a lot of risk factors that probably affected a spread of COVID to tribal areas because of scarcity of healthcare infrastructures. Doctors, especially infectious disease experts, are very rare. There is scarcity of nurses, ventilator, etc. MBBS doctor population ratio is less than 1:10,000. 85% of the people are below poverty line, semi-literate or illiterate. It constitutes around 50% of population, and not they are totally ignorant about COVID-19 prevention because of unhygienic living conditions. Example, poor hand washing, wrong coughing practices, and chewing tobacco and spitting practices. There is close community contact, huts with sharing walls, poor indoor ventilation, and high prevalence of alcohol and smoking precipitates COVID spread in tribal areas of Melghat. There's high prevalence of malnutrition, hypertension, chronic obstructive airway disease, and respiratory infections. There are scarcity of diagnostic facilities. Due to lack of jobs in tribal areas, more than 30% of the tribal youths, they temporarily migrate to cities. And when the outbreak of COVID-19 started in cities, especially during Holi, there was a reverse migration of thousands of laborers to Meghat, and they might be the COVID carriers. Due to heavy rains and very low temperature during winter may precipitate COVID crisis, as most of the respiratory viruses did, as per our study of 3,500 nasopharyngeal swabs in 93 villages. So there is disaster of COVID in Meghat due to intra-community spread. There is scarcity and irregular corona testing facilities in tribal areas, and because of costly transportation, tribal are reluctant to go to big cities for corona testing. Many cases are not diagnosed. The undiagnosed milder cases of corona are spreading COVID-19 in tribal area due to ignorance, and without proper diagnostic facilities, physicians are afraid of treating patients. And there are many deaths of non-corona patients because of coronaphobia. I do remember one story. 1 year before, when corona just started here, one young 24 years old migrant laborer attended our hospital. He was in ARDS. SpO2 was just less than 50%. And we treated that patient with oxygen and ventilator. But as it was not permitted to treat corona patients here, we have to refer the patients to cities. And we referred that patient to district hospital. And as he was kept in non-ICU setup in isolation ward because of coronaphobia, he died. Then we decided, by taking all the risk, we'll manage corona patients in our setup only to prevent deaths in such area. Lot of deaths are happening of critical patients in tribal areas due to COVID, because during referral to cities, which is a very time consuming, long distance, difficult travel through mountains and forests, and in cities, beds are not available. Tribal are reluctant to go to cities because of ignorance. There are a lot of associated problems or complications of COVID-19 in tribal area. Laborers, due to lockdown, there is economic crisis. They are not habitual of saving money as they are totally dependent on daily wages. So they are facing a lot of issues. Tribal, especially pregnant, lactating mothers, and under 5 children, they are most vulnerable for COVID lockdown induced starvation. And ICDS services were hampered during lockdown period. So it was very difficult to get hot cooked food for these people. Hence, there was increased severe malnutrition during lockdown period from 14% to 19% in Melghat. Prevalence of severe malnutrition increased significantly, and there is possibility of increased maternal mortality rate, low birth weight, premature babies, and there was increased under 5 mortality rate in Melghat. There is increase in cost and need of nutritious food. There is sudden increase in suicide amongst tribal, and there is no system for correct death reporting. So considering this background, we changed our approach. It is totally different either from UK or from Nagpur or other cities of Maharashtra. We have decided to start hospital-based and community-based treatment services in Meghat. Our hospital was open 24/7, except 1 week of compulsory quarantine by government. We treated more than 690 patients in indoor basis and more than 439 serious patients in ICU during this time. We treated more than 118 confirmed COVID patients, which seems to be less as compared to in cities, and more than 70 suspected cases were treated, as there was no facilities for diagnosis for first few months. We could manage 36 severe patients of ARDS on ventilators, and 2 respiratory failure patients were managed. More than 10 patients were managed on BiPAP. But Mahan staff is serving without fear. 7 staff developed COVID while serving critical COVID patients, but not a single staff demotivated, and they are serving poor tribal patients continuously. So we could do something for the patients. We have developed infectious ICU. We have developed isolation ward. I think personal touch and personal talk with the patients by the senior doctor is important. So we personally examine with taking due precautions by triple layer masks, face shields, and we cover the face of the patient with plastic, and we also give mask to the patients so that it will prevent transmission of infection from patients to doctor. As auscultation is one of the very risky process, but probably this method has prevented transmission. Out of these 118 cases, 34 were mild cases, 24 moderate, 21 severe, and 39 were very severe cases. So total 60 cases, COVID cases were managed in ICU. Out of them, 5 died. So the death rate was around, case fatality rate of ICU cases was 8.3%. And 3 patients, as they can afford, they preferred to go outside to CTs for treatment. And 86.67% of the ICU cases recovered, and all the mild and moderate cases become normal. When we analyze the data of very critical cases, out of total 39 cases, we gave remdesivir to 23 cases, and we did not give remdesivir to 16 cases. And out of total 23 cases, 82.61% of the patients, they recovered in remdesivir group, while 12 of the 16 cases recovered in patients where remdesivir was not given. So the recovery rate of patients without remdesivir was 75%, and p-value was around 0.6421%. So it was not statistically significant. 8.7% of the patients on remdesivir died, while 18% where remdesivir not given died. And we referred 8.7% of the patients on remdesivir as they preferred to go outside, and 6.25% of the cases where remdesivir not given. We gave tocilizumab to only 2 patients because of lack of facilities in our setup. Out of serious cases, 21 serious cases, remdesivir was given in 7 cases, and remdesivir was not given in 14 cases. 85.71% of the patients who received remdesivir, they recovered, while 92.86% of the patients who were given remdesivir, they recovered. So p-value was not statistically significant, 0.999, and we could refer only 2 patients out of them, 1 from each group, and tocilizumab was not given to single patient in severe cases, and there was not a single mortality in all these serious cases. For moderate cases, out of 24 cases, we gave remdesivir to 1 case, as he was 80 years old male patient having other associated illnesses like hypertension, coronary artery disease, and his son was suffering from critical illness. But out of 24, 23 were not given remdesivir, and the recovery rate was 100%. There were some interesting observations. There is increased incidence of diabetic ketoacidosis. Initially, diabetes was very rare in tribal of diabetes was very rare in tribal of Maraghat. There was no past history of diabetes in most of the cases. There's increased incidence of sepsis, increased incidence of hyponatremia, hypokalemia, probably due to salt-raising nephropathy in COVID. And we saw more than 6 cases of quadriparesis suddenly during first wave, probably due to
Ashish,
yeah.
Ashish,
Yeah.
can I interrupt? The
Yeah.
Regional Commissioner sir has joined,
Okay.
and
Okay.
sir has to leave for some urgent meeting. So can
Okay.
we take sir on the screen?
Yeah.
If you permit.
Yeah.
I welcome our Divisional
Thank you.
Commissioner sir, Mr. Sanjeev Kumar sir. Sir, with a very busy, hectic schedule, still working on Sunday. And I am very thankful for giving us the appointment to join us this. Can we share screen with the sir, please?
Yes, sir.
Thank you so much, Dr. I hope I'm audible. There was some technical issue here. So
Yes, sir, you're
that's why,
audible.
yeah,
You're
that's why I couldn't join you. So sorry for the delay because of this technical issue here. I'm sure we have been discussing this issue. We have been dealing with this problem now for more than 1 year, and every day we learn more, and we must interact with each other. As we all know that every day, almost every day, every week, things keep changing. And unless and until we interact and we learn what we are doing, what we are not doing, what should we do, what should we not do, I think we will probably keep committing mistakes. If you see that I was just comparing the amount of TOSI used in government hospitals and private hospitals in the first wave, and it's in multiple times. So we keep doing this kind of interaction. I think about 15 days back also, the district task force was there interacting with our doctors from the city and the division. But my request is that let's have it every week. Let us fix a day so that you don't need to tell me and I don't need to inform others, and you don't need to uh, say again and again. Maybe whichever time is convenient to doctors, probably maybe Sunday, maybe Saturday or Monday, at any time in the morning, evening, whatever suits you. Please let us know so that we can have maximum number of doctors. My wish is that not only the doctors serving in the city or in big hospitals, we must have the doctors working in the periphery, in government as well as in the private sector. Not only the treating clinicians, maybe the MBBS, BAMS, who are the first line of contact with the people. Probably they would be in a better position to advise people, guide people. आपको ये करना चाहिए, ये नहीं करना चाहिए, ऐसे होना चाहिए, वैसे होना चाहिए, so that we can have maximum number of people joining this interaction. So please let me know whenever, whatever time suits you. You can think, you can let me know. Maybe Monday, Tuesday, or Saturday, probably, I think, in the morning, evening, whichever time is suitable, that we can fix once in a week, compulsory interaction. And as we know, after the first wave, we thought this problem is over. Probably we are not going to commit this mistake now. Even after the second wave, even before it has ended, now people have started talking about the third wave. So we don't know for how long this problem will stay with us. We don't know how long it will take to vaccinate all of us, because that depends on the number of doses we have and the size of the country, the size of the population. So maybe at least 6 months, 8 months, 9 months, or 1 year. And even after vaccination, the new strains, how would they behave? So all these unknown variables are there. So let us do it once in a week interaction, maybe for half an hour, 1 hour, but that this is very important. That is one. I must say that the medical community has done outstanding work. Of course, there are issues in terms of infrastructure, in terms of the manpower, in terms of the beds, the hospital, the oxygen, the input, remdesivir and other things. But taking those limitations into consideration, all our hospitals, government as well as private, we have risen to the occasion and done a lot of service. I must say, I must thank you, appreciate you, compliment you that all our doctors, medical, paramedical community has done the outstanding work. This work we will continue. And of course, there are many learnings also that my suggestion, why I'm saying so, that once this pandemic is under control or it's over, even then we should have these kinds of discussions. And I will ensure subsequently that our elected representatives, our policymakers, our ministers also join these interactions. Though in a small group, we may not have a bigger interaction that way, but we must join how the health system should be improved. what reforms do we need in healthcare systems. So let us make it a regular habit. And once in a week, after once it is controlled, we have a discussion on improving. I think that's the mistake again we committed. After the first wave, we all forgot. And as if there was hardly any learning. What should be done? What were the learnings? How things should be improved? For example, the paramedicals. Where are the paramedical staff and the nurses in the cities? We don't have. For a city of 25 lakh, Nagpur, or many other cities, how many nurses are there? How many field workers are there? How many our paramedics are there who can go house to house for immunization, for diabetes, hypertension, and other screening work? The basic, the first line of interaction with the community. These things are not there. There are the funding as well, the hospital infrastructure as well, the hospital infrastructure at taluka level, district level, the medical education. So all these issues are there, which I am sure probably many of you have better understanding, better knowledge. And if we all join together, take up these issues with the people who, because you see, at the end of the day, every government has limited resources. In the limited resources, we have to high profile our performance, our problem, our issue. And when we high profile our issue, our problem, then the decisions are taken. So please keep in mind, after let's say about a month or so, I will ensure that some of the ministers, some of our MLAs also join this interaction. And then we can take up the issues of healthcare, health system reform, the funding part, the manpower part, the training part, the medical colleges, the district hospital, the sub-district hospitals, how should we have, what kind of interaction has got to be there with the private sector? How can we build bridges with the trust hospitals, the private hospitals? So also issues are there, but those are long-term issues. For the time being, the issue is treatment of protocol in COVID. So I'm pretty sure you will learn a lot, and please let me know. I want to make it once in a week, maybe for half an hour, 1 hour, so that and many people, many doctors serving at the periphery in Gadchiroli, Gondia, in taluka level, district level, we would like to have them also on this platform so that they also learn. We don't know, but if we do some kind of survey, we will find out that there are huge gaps in understanding, and these gaps in understanding multiply from a tertiary care hospital down to the district level, to the sub-district level, to the people in the private, in the government, in the private sector, at the village level, those people who are there. So I think those gaps need to be fixed. My best wishes to all of you. I have to go for a meeting, so please carry on.
Thank you very much, sir. And on behalf of whole of doctor fraternity, IMA promises you to be with you. Rather, we will be a step ahead in this all healthcare problem. So I promise you that we will be with you. And second promise is that we will be having a weekly webinar for the doctors who are working at the periphery. We just finalize the time and the date. I will in contact with Krishna sir and let you know, sir. Thank you very much, sir.
Hello. I thank our divisional commissioner, sir, for taking out time and attending our web program and addressing us and giving important inputs. Now I invite Ashish Satav, sir, again to continue with his session. Thank you, sir. Dr. Ashish Satav.
I don't see him online. I think he has gone offline.
Oh. I'll just try to contact him. Hello. Actually, Dr. Satav sir is having some problem, so he has sent all the details to Manju, and he will give his audio from his mobile. Just wait for a few minutes.
Hello.
Welcome, sir.
Audible?
Yeah, you're audible.
Can Manju share my screen? Can
Yeah,
Manju
yeah.
share my screen?
Yeah, I'll inform her.
हो सर, एक मिनिट.
As usual, there are a lot of problems of communication in Dharni area, Merghat area. Many times electricity is not there, the network is not there, and that's why we are facing such a problem.
Till the slide sharing starts, I'll just introduce Dr. Ashish Satav. Dr. Ashish Satav is a chief functionary of Mahan Trust. He is from 1988 by GMC Nagpur. He did his MD medicine and has many credits to his honor. But to highlight a few, he is a president of Mahan Trust, coordinator of Tribal Health Research Project, Melghat, at Mahatma Gandhi Tribal Hospital, Melghat. He has many memberships to his credit. To highlight a few, he is a member of Bhavishya Alliance, and through this he worked to benefit of more than 1 lakh tribal children. Member of Midday Meal, member of PHC Committee of India, member of Naujivan Committee, monitoring child health
स्क्रीन
and
शेयर
nutrition.
करना है.
He has
Start
many
from
awards
meeting.
to his credit. He's presented many papers. The list is unending. In one sentence, I can say he is God for the tribal people. Welcome, sir.
उन्होंने ऑप्शन नहीं रखा शायद.
सर स्क्रीन.
Good morning.
एक मिनट. इसमें कौन सा आएगा?
एक मिनट डीएनडी पे कर दो.
डीएनडी पे होगा.
है ना?
हाँ.
और स्क्रीन डायरेक्ट शेयर करो.
स्क्रीन.
हाँ.
स्टार्ट नाउ.
ओके. परमिशन खोलो ना.
एक मिनट है सर.
हाँ.
ह्याच्यावरून होत नाहीये सर. एक
Hello.
मिनिट.
हा माझा होत आहे आता कनेक्ट.
तुमचं
माझा
होत
होत
आहे
आहे
का?
कनेक्ट. हो आलं. नेट आलेला दिसतंय. हो आलं. आम्हाला शेअर स्क्रीन करायची. आम्हाला शेअर स्क्रीन.
Yeah, good.
So screen sharing has started.
Ashish sir.
Hello, Ashish sir.
Ashish are left.
एक मिनिट सर, मी पण ट्राय करते. एक मिनिट.
नहीं, Ashish has left, but his screens are shared. Yeah,
आता आवाज येतोय का?
हो हो
yeah.
हो सर.
Welcome.
येस सर, यू आर ऑडिबल.
Yes.
Ashish sir, please start from first slide only. Till now.
Pardon?
Ashish sir, you can start now from the same slide.
हॅलो.
एक मिनिट, मी माझ्या ह्याच्यातूनही करते रागिणी. एक मिनिट.
Hello, is it audible?
Yeah.
येस सर, यू आर ऑडिबल.
Sorry.
नो इट्स ओके सर.
Simply sorry.
You can start from here, Ashish. No problem.
You can start from the beginning, no problem.
Beginning. Okay.
Yeah.
Okay, but it will consume time of other speakers.
No, sir, you can.
Okay, thank you. I'll start. So good morning again. So tribal area, they are situated in mostly outskirts of the states. It's really difficult to access forest areas like this. This is our village Utawali, situated in dense forest. Mahan stands for meditation, addiction, health, aids, and nutrition. We are catering services to 320 tribal villages of Maharashtra and 100 tribal villages of Madhya Pradesh. Our base hospital is 800 km from Mumbai and 300 km from Nagpur. COVID-19 in tribal area. Tribal area constitutes around 8.9% of total population. There are 104 million tribal people and around 705 tribes. COVID is spreading like disaster in tribal areas. As per survey by IIT Delhi in July 2020, 3% of the population was infected. The tribal area of Meghat, the population is around 3 lakhs, spread over 4,000 square kilometer with 320 villages, that is 940 persons per village. The tribal area are at high risk of COVID-19 because of high prevalence of malnutrition, hypertension, chronic obstructive airway disease, respiratory infections. There are scarcity of diagnostic facilities. More than 30% of the tribal youths, they temporarily migrate to cities. There's outbreak of COVID-19 in cities, and during holy time, there was reverse migration. More than 20,000 laborers migrated to Melghat, and they might be the COVID carriers. During heavy rains, during rainy season, and very low temperature during winter may precipitate COVID crisis, as most of the respiratory viruses did, as per our study of 3,500 nasopharyngeal swabs from 93 villages. There is scarcity of healthcare infrastructures. Doctors, especially infectious disease experts, are very rare. There are scarcity of nurses, ventilators. The MBBS doctor population ratio is 1:10,000. Ours is the only hospital with ventilator facilities for critical COVID patients over 4,000 square kilometer. 85% of the people, they are below poverty line. More than 50% are semi-literate or illiterate tribal. They are not knowledgeable about COVID prevention. There are a lot of unhygienic living practices, example, poor hand washing, wrong coughing practices, and chewing tobacco and spitting practices. There is close community contact. Huts are with sharing walls, with poor indoor ventilation. There is high prevalence of alcohol and smoking, and that is the cause there is chance of disaster of COVID in Melghat due to intra-community spread. There is scarcity and irregular corona testing facilities in tribal area. Due to costly transportation, tribal are reluctant to go to big cities for corona testing. Many cases are not diagnosed. Undiagnosed milder cases of corona are spreading COVID-19 in tribal area due to ignorance, and without proper diagnostic facilities, the doctors are afraid of treating patients. Many deaths of the non-corona patients are happening due to corona phobia. Death of one youth motivated us to start treatment of COVID patients in our hospital. Due to death of critical patients during referral to cities, which is very time consuming, long distance, difficult travel through mountains and forests, and in cities, beds are not available. The tribal are reluctant to go to cities because of ignorance and fear. There are a lot of associated problems and complications of COVID-19 in tribal areas of Melghat. Laborers, due to lockdown, they are facing a lot of economic crisis. They are not habitual of saving money. They are dependent on daily wages. Tribal, especially pregnant, lactating mothers and under 5 children, they are more vulnerable for COVID lockdown induced starvation. Especially ICDS services were hampered. It was very tough for this vulnerable group to get sufficient hot cooked food from Anganwadis. There was increased severe malnutrition from 14% to around 19% during this lockdown time, and there is possibility of increased maternal mortality rate, low birth weight and premature babies. The under 5 mortality rate has been increased due to lockdown period. There is increase in cost and need of nutritious food. There is sudden increase in suicide amongst tribal because of economic crisis and frustration. There is no system for correct death report. Hence, we decided to have different approach for treating COVID in this tribal area. It cannot mimic the city approach of only hospital-based services. Hence, we started both hospital-based and community-based treatment services. Our hospital was open 24/7, except for 1 week of compulsory quarantine by government. We treated more than 691 cases in indoor basis. Out of them, 439 were critical, treated in ICU during this time. Out of them, 118 were confirmed COVID cases. More than 70 suspected cases were there because of lack of diagnostic facilities. We managed more than 36 severe ARDS patients on ventilator, NIV, and 2 respiratory failure patients. More than 10 were managed on BiPAP. Our staff is serving without fear. 7 staff developed COVID while serving critical COVID patients, but not a single staff has been demotivated, and they are serving poor tribal patients continuously since 1 year. We have developed infectious ICU, isolation ward. As I told, we have realized that personal touch and speech of senior doctor with patients is important. So daily, myself and my team of doctors, we are examining the patient from very close distance, auscultating them, but we are taking due precautions with the help of 3 masks, face shields. We are covering the patients with plastic, especially the face of patient is covered with plastic, and they have been given mask also. So probably it has reduced transmission, and there is very good open ventilation in our hospitals. We have now started ACs or coolers and keeping all the windows open so that there will be free flow of air, pure air from outside. Out of 118 cases, 34 were mild, 24 were moderate, and 21 were severe, and around 39 were very severe cases, and around 16 cases were managed in ICU. Out of these very severe cases, 5 patients died, that is mortality rate of 12.82%, while 8.11% preferred to go outside of cities because they can afford. 79.49% of very severe cases recovered, 100% of severe cases recovered, and out of total 60 ICU cases, recovery rate of 86.67% and mortality rate of 8.33%. When we analyze the data of very critical 39 cases, we gave remdesivir to 23 very critical cases. Out of them, 82.61% cases recovered, 8.7% died, and 8.7% preferred to go outside. We did not give remdesivir to 16 cases. So 75% of the cases recovered, 18% died, and 6.25% preferred to go outside. There was no statistical significant difference between the two groups where remdesivir was given and remdesivir was not given, with p-value of 0.64. Tocilizumab was given in the two cases. Out of 21 total serious cases, we gave remdesivir to 7 cases, the recovery rate of 85.7% and no mortality, and one patient went outside. Out of these 21 cases, 14 cases were not given remdesivir. The recovery rate was 92.86% and no death. So there was statistically no significance between remdesivir and the two groups where remdesivir was given and remdesivir was not given. And not a single case was given tocilizumab, and there was not a single mortality in all these serious cases. Amongst the moderate cases, we gave remdesivir to only one patient because he was old and having comorbid conditions like hypertension, coronary artery disease, and all of the other 23 cases where remdesivir not given, they recovered. There were some interesting observations. There was increased incidence of diabetic ketoacidosis. There was no past history of diabetes in most of the tribal patients during this time. There is increased incidence of sepsis, increased incidence of hyponatremia, hypokalemia, and hypokalemia-induced quadriparesis. This is probably because of renal tubular acidosis seen in COVID cases. There is increased incidence of thrombocytosis, increased incidence of coronary artery disease. Acute respiratory distress syndrome and severe hypoxia were the major complications. Many cases with severe hypoxia had very minimal chest signs or no respiratory signs. We have found that favipiravir and remdesivir has no significant advantage. Detailed analysis is going on. Steroids and low molecular weight heparin had major impact in severe cases, and we have to manage most of the cases without CT scan, without D-dimer, but we could manage it successfully on clinical basis. We found that the second or third wave, which is there, it is more serious, more young patients are infected, young patients are dying also, and the families are also involved. Happy hypoxemia is a common finding. Most of the serious cases, they are tolerating SpO2 between 80 to 90% for 10 to 15 minutes without any long-term effect. We have realized very good effect of prone awake position in very critical cases. The SpO2 is increasing from 70% to 90% just by changing the posture in many cases. As I have mentioned, just tribal areas cannot be managed just by hospital approach. So we started community COVID relief work in the form of free local therapeutic food supply daily to poor tribal for 3 to 7 months. We supplied it to 740 pregnant women and 500 under 5 children because they were the worst sufferers of lockdown. Monthly family food kits were distributed to 500 families. We distributed 40,000 fruits and drumstick plants to poor tribal. We distributed 15,000 masks to villagers and frontline health workers and provided free primary treatment in the villages to more than 20,000 cases. We involved the community from 83 villages intensively. We did intensive behavior communication in 83 villages, and we focused on 2,500 households from 33 villages. And we found that good effect of this during the first wave. There was reduced respiratory viral infections and COVID in those villages. The data from 83 tribal villages by testing 305 nasopharyngeal swabs for the cases who died or who had severe pneumonia. We tested it in NIV Pune, and we found that very rare cases of COVID during that time. We did real-time death tracking. The analysis is going on, and we did advocacy for around 6 months, and we found that after advocacy, government accepted COVID-19 patients and approved COVID-19 testing, that is rapid antigen test, which was not there for first 4 to 5 months in Meghat. And now government is collecting daily sample for RT-PCR. Bodhankar sir helped us a lot in this. Government COVID care center hospital has been started because of continuous persuasion. There is different need of tribal area during COVID pandemic, as tribal areas are incapable to handle COVID crisis. There is need of fair distribution of resources with special focus on vulnerable area. There is need of active screening for COVID-19, that is door-to-door screening is needed, if possible nasopharyngeal swabs. Community-based COVID research and care is needed. There should be COVID hospitals in tribal areas which should treat moderate to severe cases, if possible with ventilator. There should be treatment of hospitals for treatment of non-corona serious patients, and intensive awareness for COVID is needed. ASHA, Anganwadi workers, village health workers should be trained for management of mild COVID-19 cases in villages. Village kits should be distributed to such staff. There should be drugs, pulse oximeter, thermometers, BP apparatus, digital BP apparatus, digital stethoscope. PP kits and N95 masks should be given to all frontline workers, and triple layer cloth mask should be distributed to all tribals from all tribal villages of India. Drug kit should contain drugs like paracetamol, azithromycin, if possible, low molecular weight heparin, vitamin C, D, and zinc. Extra manpower is needed. There should be intense contact tracing of COVID positive cases, because as seen from developed countries and from metros of India, only hospital-based approach is not sufficient. So intensive community-based approach is needed. Prevention is better than cure. A cluster randomized control trial is needed. So now I am stopping my presentation. Thank you. Thanks a lot.
Thank you, Ashish sir. Indeed, it was a very informative and really at tribal sector, you are doing so much. I really feel that we are blessed to have you in that tribal area. Due to time constraint, the question answer session, we will take only few important questions, and most importantly, I would invite the experts for their expert comments, Jay Deshmukh sir and Anurag Bahekar sir.
I think work in a tribal area is itself a big challenge, and then to manage COVID patients with such limited resources is still much more challenging. I basically would like to congratulate our doctor from Mirghat area who has done such a major work with such limited resources. I might as well ask him that is he treating patients with azithromycin or doxycycline over there, or is he putting the patients on ecosprin in patients in whom we think that there could be major vaso-occlusive complications?
Sir, we initially started azithromycin and doxy, but later we found that as per our experience of last 23 years in this tribal area, most of the serious cases who especially has sepsis or pneumonia induced multi-system involvement, they responded nicely to ceftriaxone and amoxiclav. So we tried in all our serious cases and very critical cases with amoxicillin, clavulanic acid injectable and injectable ceftriaxone, and the response was really very good. Only 2 of these 60 patients required meropenem. So most of the, and for mild moderate cases, we give doxy or azithromycin. And second question, as there was no facilities of D-dimer or CT scan like this, we empirically treated all serious cases with low molecular weight heparin, and we got probably good result.
I think your point is very well taken, because personally, I feel, and all the guidelines also suggest, irrespective whether you are practicing in city areas or sort of rural areas, that doxycycline and azithromycin, which are supposedly to be first-line drugs by most GPs, primary, secondary care physicians, is given blindly along with favipiravir. And I believe that doxycycline and azithromycin has no prophylactic use in patients with COVID infection. So you better not give doxycycline and azithromycin unless there is clear-cut evidence of some mild bacterial infection. So your point is very well taken. Good that you're not giving, and prophylactic antibiotics like azithromycin and doxycycline have no role to play. And I would appreciate if the IMA can issue some guidelines to all its members, mentioning firstly that don't give doxycycline and azithromycin as a routine when the patient comes to you for the first time. See, what's going to happen is that over a period of time, when this COVID wave goes away, and if the doctor wants to use azithromycin and doxycycline, most of the bacteria are going to have resistance against that, and these two important drugs will not be of any use. Thank you very much.
Thank you, sir. Anurag Bahekar, sir, your expert comments, please.
So the optimum use of resources is really commendable. One question I wanted to ask that without D-dimer, are you using OD dose of low molecular weight heparin or BD dose?
Sir, if the cases are serious, we are using OD, but we found that they are becoming very critical, or there are conditions like acute myocardial infarction, or we are suspecting pulmonary embolism clinically, then we are giving BD doses of low molecular weight heparin.
Yeah,
Right.
yeah. Let me intervene over here. See, the point is that any patient who gets hospitalized, can you hear me?
Yeah,
Hello?
yes, sir. We are getting.
Yeah,
We are
any,
getting you, sir.
yeah, any patient who gets hospitalized with COVID infection, and he will get hospitalized only if the oxygen saturation is low and is requiring oxygen. In those instances, low molecular weight heparin has to be given. It has to be given in an OD dose in all patients as a prophylactic, and dose is 0.1 ml per 10 kg body weight as enoxaparin. Now, in patients in whom you want to give as a therapeutic dose, then not the preventive but therapeutic dose, then BD doses have to be given. So, in any patients wherein, in case you have facilities that the D-dimer levels are high, or as has been mentioned that he has had a recent any vascular event, then BD doses are to be given. When it is a prophylactic dose, then a single dose to be given, single OD dose.
So
And
we
what is
treated
the-
most of the serious cases with single doses, and with very critical cases where severe hypoxemia is there, we treated it with BD doses.
Yeah, with severe hypoxia, agreed.
Yeah.
As a preventive measure, you can give BD doses. Yeah.
And what is the steroid that is available there? What are you using?
Sir, we are using dexamethasone mostly, injectable dexamethasone, and very few cases, 2 or 3 cases we could who could afford, we gave them methylprednisone. But mostly, most cases responded very nicely to dexamethasone.
How much dexamethasone?
See, we started with 6 milligram intramuscularly in the morning.
I see.
Yeah.
Yeah.
OD
I think
dose.
I think your point is very well taken. That is a standard dose as per even UK and USA guidelines. 6 milligram daily for about maximum 10 days time. I would like to caution you that we should not exceed for 10 days and more. A, if the patient has stress-induced diabetes, that has to be treated with insulin. B, and if the patient is already diabetic and who has further increment in his blood glucose level, make sure that you treat his blood sugar very decisively, very aggressively, and normalize it to the best possible extent, because now we have started getting more and more cases of mucormycosis. In fact, last 5 days we are seeing 2 patients almost every day, and even tribal areas the incidence of mucormycosis might be a little bit more than the urban areas. So be careful. The major reason for mucormycosis would be hyperglycemia in a diabetic patient, high dose steroid or tocilizumab.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, Jay Deshmukh sir, Anurag Pahekar sir. Ashish sir, only 2 questions are there. Can I just ask you?
Yeah. Please ask, madam.
Dr. Ashok Pathak sir has asked, what is the mortality rate in the Melghat as compared to the other rural and urban areas? I think you have answered this still.
Yeah. I like to give 2 answers to this question. One, overall mortality rate, because a lot of experts are there. We are studying overall mortality in the economically productive age group, that is 16 to 60 years, since last around 19 years. And we found that the age-specific mortality in this age group is more than 400 per lakh population. While in the cities, it is around 197 like that. 176. So it is 2.5 times that of cities. For COVID, our community data will be ready by May, end of May, but it is around, I think, 4 to 5%. Now, I'm not exactly sure as the data is not ready.
And sir, just one more. Is there any role you have seen giving preventive medications like vitamins, ivermectin? Has they played any role?
Actually, we did not try ivermectin, but we definitely give vitamin C and vitamin D and zinc to almost all the patients. That was the only treatment we give along with paracetamol. Otherwise, for most of our cases, we did not give any other medications.
I think if I intervene, ivermectin is a drug which has been found to be useful, because when the virus enters the human cell, the replication of virus has been found to be low when ivermectin is used in the dose of 12 milligrams daily for a period of 5 days or so. So ivermectin can be given. However, in patients who have been hospitalized, ivermectin has no role to play to that extent. So in all OPD patients, give ivermectin, but at the same time, make sure that you don't give hydroxychloroquine.
Yes, sir. Thank you, sir.
Thank you, sir. Very important.
Ashish, sorry, can I ask one question, please?
Yeah, Srikant.
Yeah, Shrikant here. You just mentioned you had, I think, 36 patients on ventilator. Could you please tell me what was the age profile and the comorbidities with those patients?
Actually, the age profile was in between 40 to 60 years mostly. There were a few cases in the age group of 30 to 40 cases, for 30 to 40 years also. And the most common was ARDS, then probably pulmonary embolism, severe hypoxemia, and bilateral extensive pneumonias. These were the major indications. Then sepsis-induced multi-system failures were the major indications for ventilator management. And as I told, in 2 to 3 cases, there was severe hypokalemia, which leads to quadriparesis and respiratory paralysis, where we have to put the patient on ventilator.
Okay. And any of these patients were having any pre-existing comorbidities?
Some of them, they had diabetes, hypertension, and chronic obstructive disease. But actually, we are analyzing the data, and it will be ready by end of May.
Okay, good. Yeah. Thank you.
Thank you, Ashish sir, for a very informative talk. And the work you are doing is really commendable. Thank you so much.
Thanks, madam.
Yeah. Now, I invite our second speaker, Dr. Shrikant Ambalkar. He is based at UK at present, but he's student of our own GMC from 1988 batch. He's presently consultant and head of service department of clinical microbiology and infection at Sherwood Forest Hospitals NHS Trust, Nottinghamshire, UK. He did his MBBS and MD from GMC Nagpur, FRC Pathology in UK, DTM and H from London, and DTM from Glasgow. He has got expertise in special interest in critical care infections, ortho infections, tropical and travel related infection. He was instrumental in establishing gut microdata transplant service in East Midland region for first time. He is a key member of COVID-19 management group at his hospital. So let's learn from him his perspective of management of COVID-19. I welcome you, sir. Dr. Shrikant Ambalkar, please unmute yourself.
Sorry, I'm just having problem with sharing the screen. Okay, can you see the screen?
Yeah.
Yeah, okay. Good morning. Thanks for inviting me. I'm just going to talk about...
Can you do full screen? Full screen, please.
Yeah.
Can go for a full screen view, sir? Yes, thank you.
Yeah. Okay, so this is a just brief plan of my talk. I'm going to talk about the current COVID situation in UK and some treatment protocol and evidence behind those protocols. I will briefly mention about various variants which are circulating, and a brief about a study, a siren study, which I'm the principal investigator for this national study at my hospital. So this is just to show you how this COVID pandemic has planned in UK. So we had a first surge in, I think, during April, May time last year. And then it got better during summertime, like July, August, September, we were doing okay. And then suddenly it started having increased number of cases, which we had a very high peak after the Christmas in January, February. Then the government here took the decision to have a lockdown, and now we're seeing the decrease. So things are getting better. I hope this will remain same. This is the current situation in UK. So at the
Shrikant,
moment of time,
just a minute. Can you interpret? Can you start your video? You are not visible.
okay.
Just start your video.
Do I need to stop sharing?
No, you share. You can.
No, it will be at the left hand side bottom. So you just need to click on start video.
Yeah.
म्यूट के बटन के बाजू में है स्टार्ट वीडियो
I can't see anything. Just a minute.
you can continue if you are not able to do it.
So this is just
You need to share the screen again.
yeah. So this is the current situation. So we currently the numbers has dropped significantly. So daily we are getting around 2,000 cases and around
Because your
7
slides
deaths.
are not shared. Sorry
Sir,
to interrupt. Your slides are yet not shared with us.
Okay. Start your screen share, sir.
Right, sir. We can now see you. Just
Yeah.
click on the share screen option, which is right there at the bottom center. Did you find a green color button saying share screen?
Yeah.
Okay, sir. Great.
So I need to share the presentation.
Yes, sir. Right.
Yeah.
Sorry, just.
You can minimize this. Yes, sir. Right. Yes,
Can
and
you
full screen mode. Exactly, sir. Thank you.
Thanks. So this is the current situation. So we are having around 2,000 cases per day and 7 deaths per day. At one point, at the height of this, the second wave, we were having around 60,000 cases per day, and now it's 2,000. So things are getting better. Hopefully, it stays like this. This is just to show the comparison between this pandemic in 2020-21 and the Spanish flu pandemic, which we had in 1918 and 19. So if you see, it's exactly mimicking. There was a first peak, and then we had a second peak now, and probably if you see at the Spanish flu, there was another third peak. So we are expecting a third peak here, although it's not similar virus, but it is behaving like the peak. The pandemic is behaving like that. So we are preparing, the government here is preparing for the third wave, which probably they're expecting in October. Okay. This is just data from my hospital, which I can't share the mortality data yet, but it's not in the public domain. But this is just to show you that testing. So we have done around 100,000 tests in last whole year. And the positivity was around 4%, 4,400 positive cases. We did admit around 3,000 patients, and a significant proportion of patients died. The most important thing for us was that the patient who died, they were above 75, 80 years. And in those patients, we didn't offer them this ventilator support and all this thing, because most of these patients were just given palliative care. The reason for that was because during the first surge, there were so many patients, and we have to prioritize which patient gets the best treatment, and what is the how we can save the younger or fit population. So that was the, I mean, those were the quite difficult decisions for the doctors treating those patients. So currently, the vaccination program is going very well in UK. So at the moment, around 34 million patients, so general population is vaccinated with the first dose, and around 14 million has had their second dose as well. So what we think, how these things have turned in the right direction now is because of the 2 or 3 major interventions by government. So the strict lockdown was quite important, which started in, I think, during December time, and now we are coming out of that when the cases are very, very low. So test and trace was quite important, and there was this effective vaccination strategy has helped to flatten the curve. So at my hospital at this point of time, we just have got 3 patients on our ITU. And if you see, I mean, it's quite interesting, these 3 patients, which I'm really happy to share this. We had these 3 patients for almost for more than 2 months, really. So the first patient is like 72 days, the second surviving patient is 54 days, and the third one for 31 days. And all these patients, and I will explain you how we manage, these patients are getting only supportive treatment, and we do not use a lot of interventions which has been used in other parts of the world. It's a quite minimalistic approach. Currently on the wards, we've got only 11 patients, and there were no new admission for last 4 days. So things are getting better, improving. So what do we do for the treatment? We have got national guidance, which is National Institute of Health and Care Excellence. This is our national body which provides this rapid guidelines for managing COVID-19, and they keep on updating every now and then, because I mean, we have seen that the evidence is evolving so rapidly. So the things which we were doing last year cannot be relevant now. And as we all know about hydroxychloroquine fiasco, which was promoted by Mr. Trump, unfortunately, and we know that there's nothing in that treatment. So the guidance keeps on changing quite quickly, so we need to be up to date with this, and the national body also, they keep on updating the guidance regularly. So there are so many options for the treatment, which you all know. There are so many experimental drugs, and this is the list of drugs which are available, which are being tried in clinical trials. We know a few of them works, most of them don't, but they are being investigated. So I don't want to go through each and every, but I'll just mention a few of them. So what is guidance, UK guidance to manage COVID patients? So we have got a very minimalistic approach, and we do avoid polypharmacy. We do avoid unnecessary diagnostic tests, no unnecessary pathology tests, no CT score. I think, in fact, not many of our radiologists here, they don't understand CT score. And the most important thing is the supportive management. And I'll explain what we do exactly. For the mild cases, there's a very good communication strategy here from all levels, the government and the media and everybody, that mild cases, just stay at home and just take paracetamol. Don't come to hospital. That's the message we all give to those people, and that is important, because we don't want to flood your hospitals with these patients and occupy the beds, and the patient who needs actually the intensive treatment, they won't find the beds for them. So thus this strategy is quite important and it's working. So during the first message which the government did is stay at home and save the NHS and save lives. This is the communication strategy which has worked. Although in that there was few instances where people just stayed at home for they didn't come or they didn't seek medical care for other reasons, and few of them might have died. But that was unintended consequences of this strategy. For moderate infections, again, these patients get, if somebody has got clinical signs, they are breathless, they have fever, and the oxygen saturation is low, below 94, then those patients get oxygen supplementation. They get admitted into hospital, they get oxygen supplementation, and also they get steroids and anticoagulant prophylaxis. For severe cases, yes, we do admit them. Most of them would go on the intensive care, and this patient get only supportive treatment, dexamethasone, anticoagulant prophylaxis, and tocilizumab. A few of them. This is which we started recently. I just want to mention about the diagnostics. We don't do all these fancy tests, interleukin 6, D-dimer, unless we are suspecting PE. We don't do your ferritin and all the inflammatory markers. All these interventions are based on the clinical criteria, and the only clinical criteria is breathlessness, hypoxia, low oxygen saturation. That's it, really. We don't need CT scan to do that unless you are suspecting PE or IMA or any other complication. So it's quite minimalistic approach. And this is just a protocol from my hospital. Just one thing I want to point out, we had remdesivir in that, but now after that solidarity trial, we stopped using remdesivir. So what is the evidence base for all this for our practice in UK? So I'm sure you must have heard about recovery trial, which is from UK, which is a quite big trial. Then the second trial is REMAP CAP. Again, this is a global trial. I think we've got 21 countries, the participants. Solidarity trial was conducted by WHO. Which had around 20, I think it's almost 30 countries and 405 hospitals all over the world. And the fourth trial, principal trial, which is for the patients who are in the community, and this again UK-led trial. So a few things about the recovery trial. This is 183 NHS hospitals in UK are involved, around 40,000 participants. And this is an open label trial, randomized control open label trial with multiple interventions arm. And these are the interventions. So dexamethasone, hydroxychloroquine, azithromycin, convalescent plasma, tocilizumab. And these were the first 5, and now they have included monoclonal antibodies, cocktails, and baricitinib and dimethyl fumarate. All these interventions were tried. The first 4, we have got some evidence now. So the hydroxychloroquine hasn't shown any benefit, so they stopped using that. Azithromycin, no benefit. Convalescent plasma, there's no evidence, they have stopped using that as well. The only thing which has shown some clinical benefit is dexamethasone, and that I will talk about it later. Tocilizumab has shown some benefit, and now they are investigating this monoclonal antibodies and other stuff. So the primary endpoint for all these studies was mortality, all-cause mortality within 28 days of randomization, and the secondary endpoint, time to discharge from the hospital. The only clear benefit, dexamethasone arm from this intervention trial has shown significant benefit. Rest of the others are not that significant. This is just to show the dexamethasone benefit. So if you see, it is quite beneficial for patients who need supplemental oxygen and those who need invasive mechanical ventilation. For patients who has got mild infection, who doesn't need any oxygen, in those patients, there is no role of dexamethasone or steroids. So you just need to bear in mind, because otherwise a lot of people with mild infection may get dexamethasone, and that can be harmful. As Dr. Jay Deshmukh had just mentioned, we might see this mucormycosis and all other secondary bacterial infections, fungal infections with the overuse of dexamethasone. We must avoid that. The another thing which I just want to mention is remdesivir, which I think in India this has been a bit all sort of panic going on about this. We used to use remdesivir for few when the first clinical trial result, interim result came out in I think June, July time last year. We started using that, but after this major trial, the Solidarity trial by WHO, which was quite bigger trial, and that has shown no difference in mortality or time to recovery. So after that trial, we stopped using that. We don't use, or most of the hospitals in UK, they don't use remdesivir at all, and we don't find any difference in mortality or anything. And this is quite controversial topic. I think there are some people who would argue because they have done the subset analysis in this ACTT1 trial, which was sponsored by NIH USA. They did show some difference between some benefit in time to recovery. I think it was 4-day benefit for time to recovery, but there was no difference in mortality in both the treatment and control arm. It's just quite controversial topic, but in UK, most of the people, doctors or the trust hospitals, they don't use remdesivir at all. There was another study from China that didn't show much significant benefit with remdesivir, and there are a few other studies, good quality studies, they haven't shown much benefit. So I think I'm not sure what is the rationale for having remdesivir in your national guidelines. Although I must admit that in the UK NICE guidelines, there is a conditional recommendation, and they just say consider remdesivir, and they have used this word consider. There's no actual recommendation to use it, but and that's why we stopped using that. And after reviewing the Solidarity trial, which is good trial, you can argue that this compared to ACTT trial, which was from the US, the study design was better in that trial, but the Solidarity trial has included so many of the numbers were so big, and it's a multi-center trial with multiple patient population. So we probably are happy not using remdesivir at this moment of time. There's another issue with this convalescent plasma therapy. There were two trials, UK trials. First one was REMAP-CAP, and the second one was recovery trial, which I just mentioned. This was one of the treatment arm, intervention arm in those trials. And none of this trial have shown any benefit at all. So we stopped using plasma therapy as well. So previously we used to give in the trial setting, not as a recommendation, but it was just in the trial setting. Since January, when these findings were published from both the trials, we stopped using plasma therapy as an intervention in those patients. And I believe there was one trial from ICMR which also hasn't shown much difference. So I think we are more certain now that this modality of treatment doesn't work. And another important thing to remember with convalescent plasma is there's a lot of safety warnings and potential adverse events with all these things. And this is the list of all the adverse effects with plasma therapy we must consider. It might be harmful as well, and there are certain theoretical risks of this antibody dependent enhancement of infection and susceptibility to reinfection. I think one must consider whatever intervention you are using, we must be absolutely sure about whether there shouldn't be any harm with that intervention rather than any benefit. Uh, Another important intervention was this tocilizumab, which is a interleukin-6 inhibitor. There are multiple studies. Most of the studies has got problem with the study design. There are not many participants, or the sample size is small, but one study which we had here, this REMAP CAP study, has shown a significant benefit as far as the mortality is concerned. So there was 8.5% reduction in mortality, and also there was improvement in time to recovery. And because of that, the national guidance include tocilizumab now. So we started using tocilizumab recently. So in my hospital, we have used tocilizumab and another was sarilumab in 41 patients up till now. And I have to say, yeah, I'm not sure whether it's that great, but yeah, we will analyze our data later. We had 11 deaths in that treatment arm, so we will compare it to the controls because that is more important. You just have to, whatever you are using, you need to compare with the controls, and that's when you can make a proper conclusion. There was another study, I think it's a Brazilian study, had shown no benefit at all, and in fact there was harm as well. The important thing with all this study, you need to investigate in your local population, because the tocilizumab may be beneficial in UK population, but it may not be in. You can't extrapolate those findings for the Indian population because there are differences, and it is important to have our local data. I haven't seen any study from India, but I may be wrong. There might be something there, and that's why they might have included in the national guidance, but I haven't seen anything at the moment. So what are the criteria to use the tocilizumab? So we have got quite strict criteria, and just read out. Patients, they should be, or they should have commenced on corticosteroids or dexamethasone. They have not had another interleukin-6 inhibitor during this admission. There's no evidence of bacterial or viral infection other than SARS, because that might be worsened by tocilizumab. And they either need supplemental oxygen and have got C-reactive protein level more than 75 milligram titer. We don't do, as I mentioned, we don't use this fancy investigation, interleukin-6, the dimer, ferritin, and all this thing unless indicated. And another criteria is patient needs to, they are within the 48 hours of starting, high flow oxygen, continuous positive air pressure, non-invasive ventilation or mechanical ventilation. These are the strict criteria, and we try to follow those. So just a few slides about the WHO Solidarity Trial, which was a quite a sort of adaptive trial, open label, randomized control, conducted in 405 hospitals across 30 countries. And they investigated remdesivir, hydroxychloroquine, lopinavir, and interferon B1, beta 1A, which I think one of the Indian company had recently was given license to market this interferon. Having just going through the findings, what they found, none of these intervention has shown any benefit at 28-day mortality. So WHO was quite clear about, they did recommend against all these intervention. They were quite vocal about recommending against remdesivir, and I'm pretty sure that you must have heard about Somaya Swaminathan, who is a chair for scientific committee. She was quite vocal about this, and she has given loads of interviews, and they don't recommend remdesivir at all. Just one thing about ivermectin, I think Dr. Jay Deshmukh just mentioned about that. So ivermectin inhibits the replication of SARS coronavirus in cell cultures, and that's the fact. What we need to understand the concentration to inhibit this SARS virus in the cell culture is quite high. It's almost 4 times high what you could normally achieve in vivo in patient, and that is the main thing. So if we can't achieve that concentration in human body, then I don't think there's any much benefit with that. Having said that, there are many studies, but those studies which has shown some sort of benefit, but there's a problem with those studies. They are very small studies. They've got incomplete information, and there are loads of methodological limitations. On the basis of that, NIH doesn't recommend this. A Public Health England or NICE guidance doesn't recommend ivermectin for any indication, and also WHO has clearly said they don't recommend ivermectin at all. So I'm not sure whether we should be using that even in the initial phases as well. And the evidence at the moment is just from the few observational studies. They are not very randomized control blinded studies. So it's very difficult to interpret those results. Okay, so this was about all this, what we are doing as a treatment interventions in UK. Just to summarize, what we are doing for mild infections, we just advise patient to stay at home, take paracetamol, that's it. Don't come to hospital. That's the active advice given to from all the spheres, from the politicians, from the administrator, from the government, and from the doctors and the hospitals. If patient has got some sort of breathlessness, hypoxia, oxygen saturation start dropping, we get them admitted, give supplemental oxygen, they get dexamethasone, they get anticoagulant prophylaxis, low molecular weight heparin, and that's it. If patient deteriorate for the severe infection, only 3 intervention: dexamethasone, tocilizumab, and anticoagulant prophylaxis, and all the supportive treatment. What we have seen on the intensive care, because I get involved in most of the intensive care patients, we got MDT and we do review all the patients from infection point of view. I'm quite heavily involved. During the first surge, we had around 40 patients on our ITU with a mortality of 6. 6 patients died, and there were loads of issues. So there were some lessons learned from that surge. During that period, we didn't know, nobody knew about how to treat this patient. We had loads of patients with quite severe clots in the venous clots and all the other stuff, because at that time there wasn't any recommendation about anticoagulant and all this thing. Then a lot of these patients ended getting very broad spectrum antibiotics because they all were spiking temperatures like weeks and weeks. So we later on realized that there's not much evidence for that, and there was a good paper article published recently. During that time, there was increased usage of antibiotics significantly, and there were increase in hospital-acquired secondary infections as well, because there's working with all these years, the PPE is quite difficult, and sometimes you don't follow all the other major infection control precautions, like especially line infections are quite important stuff. So this is just in summary what we do here in UK. It is quite a minimalistic approach. We don't give any, like most of the patient would get only 2 or 3 drugs, and that's it. Now I just want to talk about this Siren study. This is a study which is funded by Department of Health, and it's coordinated by Public Health England. Susan Hopkins is the national chief investigator. There are so many, I think it's being almost 130 NHS hospitals in UK are involved in this thing. I'm the principal investigator for my hospital. So this is the study regarding immunity and reinfection evaluation in this patient, because when it all started, we all were interested to know how long this immunity would stay. If somebody gets the infection, how long would the immunity last for, and whether they would be susceptible of getting reinfection. And this study is it's a nice study, and most of the participants are healthcare workers, doctors, nurses, and all the other admin staff and support staff in working in hospitals. We got around uh, 40,000 per a cohort of 49,000 subjects now, which is quite a big number. And there were so many research gaps before this study started. So we knew that there is antibody response. So we wanted to know, are these antibodies are neutralizing antibodies or protective antibodies, or whether they protect from reinfection or not, how long this antibody lasts for, and what level of antibodies are protective, and does cell-mediated immunity like T-cell immunity plays any role? So we with all this in mind, they started the study, and this is the primary objective for the study. And there were a few other secondary objectives. I just don't want to go through this thing. I'll skip it. And now we got some publication out of this study. This paper was published in Lancet in January, I think. Yeah. So this is an interim analysis. So because in this study, they are going to follow all these participants for 18 to 24 months just to see how long the immunity and reinfection rates would be. So this interim analysis did show that it was associated with 84% lower risk of infection in patient who has had some sort of antibody. So it's quite good finding. And then there was another paper which was published, I think in April in Lancet. So they concluded that the vaccine, because now since December or January, they have included participants who were vaccinated. And they just want to see whether how many of these vaccinated patients would get reinfection. But there was a significant drop in this thing, and it's quite reassuring. So just to summarize, this study, when it will finish, like for 18 to 24 months, this will help us to improve our understanding and knowledge about the SARS and coronavirus immunity and reinfection. And why it is so important? This is important because the findings of this study will have huge implication on vaccination strategy, because that will tell us when to give booster doses, when to revaccinate, and this is quite important. Okay, so I would just briefly mention about the variants, which I think everybody knows about this thing. So what we have got, this UK strain, which was initially identified I think in September. So it started in September. We started seeing many patients in December because that strain was associated with increased transmissibility. There were increase in hospitalization, and possibly, I mean, we can't say, we're not absolutely sure about this, whether there was increased mortality or not, but the small cohort study, which they did mention that there was possibly a slight increase in mortality as well. And this was initially identified in Kent region of the United Kingdom, and then it spread to, I think it's almost spread to 83 other countries now. Another important strain variant is South African variant of concern, which is B1351, and they also have got some different mutations. Brazilian variant is of concern is P1 strain, which also has got associated with increased transmissibility and mortality as well. And now we've got this Indian variant of concern. So every person who is returning to UK from India, they are being monitored, and there's a very, very excellent surveillance mechanism here. So up till now, they have found around 400 cases in UK. And the initial analysis, although I have to say there's no publication out yet, but Mr. Hancock, the health secretary here, he made a statement in Parliament a few days ago that there are only 400 cases, and initial analysis doesn't show that this is associated with increased mortality, although it is associated with increased transmissibility, which I know because they also have this E484Q and another L480 mutations. So they are monitoring, and we have got a very good genomic sequencing surveillance program, and that is quite important, which is going to help for the vaccine development. Already, UK is preparing for the third wave, which the mathematical modeling does suggest that it will be milder because most of the population will be vaccinated by July, and even if it's a different variant, which we still might have some protection, and there won't be many patients with severe infections, and there won't be that many hospitalization. But this is just a speculation. We know we've been wrong for many times with this in this COVID pandemic, so nobody knows. But this is just depending on the mathematical modeling. So the government is planning for the booster dose in October. So I think they have already ordered enough doses of Pfizer, Moderna, and Oxford vaccine. They are working on other vaccines, whether they need to include these variants. They have already started working on that. So just to summarize, there are so many unknowns. We know that there's lots of evidence. There are lots of new things coming out almost daily, and you find it difficult to keep up with all this evolving knowledge and papers and all this evidence. So it is important to know about this. We should try to avoid the temptation to use the unproven therapies. It is okay to use it in a trial setting, but I don't think we should be using all these unproven therapies regularly on every other patients because this polypharmacy and giving all sort of different drugs in a go can be harmful. And the reason I'm saying that, and I'm quite concerned about this thing, because we haven't studied all the drug interaction. Like, say, for example, you are giving favipiravir, remdesivir, ivermectin, vitamin C, D, Z, zinc, all this thing. We don't know how all these drugs interact with each other and just may cause harm. And because we are not monitoring those harms, we don't know. But I think it's important to use the intervention which has been proven. There's another important thing. The last thing would be vaccination is quite important. There's problem with vaccination hesitancy. We need to address those issue with proper communication. Here, I think we got very, very good support from the media as well as the government and everybody. So the vaccination drive is going very well. And hopefully, we're hoping by July, end of July, most of the adult population will be vaccinated. So that's it, really. Thank you very much. And I'm happy to take questions.
Well, Dr. Shrikant, thank you very much for an excellent presentation. Do you use colchicine there in UK?
Sorry?
Colchicine.
Yeah, so colchicine is, we don't use that, which is, colchicine is one of the intervention in this trial, the principal trial, which is being conducted, and this is one of the treatment arm. There's no evidence at the moment. It is being used only in the clinical trial, and hopefully we'll get some results soon, and then if found to be useful, that will be included in our national guidelines. At the moment, what I have seen, the evidence is not that great, so they don't recommend to use it at this point of time.
What do you think would be the utility of Viragin in India, which is an interferon peg interferon A in
No,
India?
I'm not sure how that got. Sorry, I don't know much details about the product, but the trial, which I think it's a remap cap, has shown no benefit with interferon one. Sorry, beta 1A. That hasn't shown. Oh, and both the interferon hasn't shown any benefit at all. So. Sorry. And if even if you look at that their product, they said that there's just a benefit of 3 days for time to recovery, which is not that great. I haven't seen any publication from India about that product, and we just need to critically evaluate what they are saying, whether this is true. But the remap cap trial hasn't shown any benefit with this product.
In India, in particular, oral anticoagulants are being given in the new oral anticoagulants based on the D-dimer values at the time of discharge. What is your opinion on that?
I don't think there's no recommendation to give any prolonged courses of prolonged courses of anticoagulant after discharge. I think a patient we just stop it when the patient is discharged. So there's we don't give it in the community.
Can you give just a 1 minute on this in pregnancy? If we are seeing lot many patients of COVID in pregnancy, what are the basic recommendations there?
In what sense? I mean,
in recommendation in use of drugs, in terms of treatment, in terms of heparin.
Yeah, I think the treatment. So there's not much evidence for anything in pregnancy. All these intervention hasn't been tried because all these trials didn't include pregnant patients. So it's quite difficult to make a official recommendation. But they are being treated as a normal patient. So, say example, the only intervention which we have got is steroids, so there's no problem with that. Anticoagulant, no problem with that. And the third thing is tocilizumab. That again, we just need to have have to inform the patient about this thing, that this is a product which has not been investigated in pregnant patient, and it's informed consent, and if patient wants, and that's okay. So I don't think there's any special recommendation for this thing. Even for all the other things, remdesivir, we don't know about whether this is associated with any side effects in pregnancy, specifically fetal deformities and all this thing. So again, we stopped using remdesivir anyway. So just one thing about vaccine I want to mention about in vaccine in pregnancy. The current recommendation is we should be giving vaccine to pregnant patients. We have got two options here. We got Pfizer and we got AstraZeneca Oxford vaccine. And what they recommend is, because both Oxford they haven't studied it in pregnant patient. There's evidence now that around 90,000 pregnant patients. 90,000 pregnant patients.
91, 92 saturation.
Yeah. So the recommendation here is to give Pfizer vaccine to the pregnant patient.
One more thing, then in India, in recent times, we have had acute shortage of tocilizumab. The number of patients over here who are critical are huge. We have used ourselves more than 100 tocilizumab so far. And now, is there any role for giving other maps? Tocilizumab and other which are available.
I think we got two products. So I got sarilumab and tocilizumab. These are the only two. I'm not sure, and I can't comment on that because I don't know about the other products in India. So I'm sorry about that. But the first thing would be, do you know any good quality study in India with these products?
Not so far.
No. So my worry is, and it may be just, I don't want to sound patronizing. Sorry for that, but I think we should not be using this any intervention without proper study in Indian population. And as you mentioned rightly, we are seeing a lot of mucormycosis, and it's been reported now quite oftenly from India. And that maybe yes, we need to think about. The benefit might not be that great, and the side effects and the harm could be more, because if you see what the trials have seen, it's 8.5% mortality benefit in tocilizumab arm. Again, this might change, because once we start recruiting more and more participants in these studies, then you might find completely different. And that's what happened in the hydroxychloroquine issue in last year. So my suggestion is, like, we should be very careful about using all these interventions. And tocilizumab, certainly, we have seen patients. We did see, if you compare to the first surge, first wave and the second wave, we have seen when we start using this immunosuppressant, there's definite slight increase in the secondary infection. And another important consideration is we need to screen for all these things. Hepatitis B, C, HIV, and all these things, even tuberculosis. I don't think we get time to screen all these things, because those infections can be reactivated, and the immunosuppression with the tocilizumab can stay for 90 days. And this patient may be getting something now, they might be getting slightly better, but they might have long-term consequences. They may be coming back with full-blown fungal infection, secondary bacterial sepsis. So I think it's quite easy to do the study as well. If you've got hundreds and hundreds of patients with this thing, we just need to make sure we get some control population as well, and compare it with, and just see whether there's any benefit or not.
Okay, thank you.
So what proportion of your ICU cases you found invasive fungal infections?
Yeah, so what we do, mucormycosis is not common, so we get Candida and we get Aspergillus. So Candida, we don't treat all this Candida, which we isolate from sputum and tracheal aspirate, unless there's clinical evidence. But we had a couple of cases with Candidemia as a line infection. So that is quite, and that's not an increase in any sort of increase in those infections compared to what we used to get previously as well before COVID. So nothing new about that. The second thing, which is definitely of concern, is Aspergillus. So there are loads of papers now, a lot of evidence. So patients with COVID, they are more susceptible for Aspergillus infection, and that we found even with this, the severe flu cases as well, swine flu cases, we did find that time as well. So there were 10-12% increase in invasive aspergillosis. So what we have started, and there was an excellent paper in Lancet. They have got some preliminary guidance about how to monitor these cases and how to treat those Aspergillus cases on ITU. So there is a recommendation now. So we do sequential screening, so weekly screening for Aspergillus infection. So what we do is beta-glucan is a serological test, and also galactomannan, which can be done on your bronchial alveolar lavage sample and also in the blood. So we do sequentially, and if there's a cutoff, like the index value more than 2 or 3, whatever we agreed, if it's a significant positive, and we get something from the culture, and also depending on the radiological findings and the clinical deterioration, so we would start antifungal dose only to those patients for Aspergillus. Otherwise, we don't give antifungal at all. So the antibiotic usage is quite restricted in ITU. The first patient, the 3 patients which I have mentioned in my talk, they were there for 72. First one was 72 days, second 54, and third 31 days, and they are alive. They are going up to the ward now, and it's quite important. I mean, they only had very few interventions as far as the COVID is concerned. their stay was quite stormy on the ITU. They did have VAP, they had Staph aureus bacteremia, and we treated with just flucloxacillin, got better. Second patient who had some Klebsiella bacteremia, got better on the coamoxiclav only. So we tried to avoid broad spectrum antibiotics. We tried to use rational antibiotics, and patient get better. So that's it.
And what is the duration of steroids that you are using in these chronically admitted patients?
I think 10 days is a normal.
10 days.
Yeah.
Dr. Shrikant, it was indeed an informative talk and an eye-opener for many polypharmacy, polydrugs therapy, which you said is to be avoided. Due to time constraint, I think you can just go in the question answer box and answer the questions by messages. Is that okay, Shrikant?
Yeah, that's fine. Thank you.
So that we can go ahead with the another talk.
Yeah, thank you.
Yeah. Thank you, Shrikant, for the informative talk. Now I invite our next speaker, Dr. Yogeshwar Kalkonde. He's done MD Medicine, MSc in Clinical in USA, MD in Neurology at USA. He did his MBBS from IGMC, Nagpur. He is trained in clinical medicine, neurology, clinical research, and worked in basic sciences, clinical and public health research. I welcome you, sir. You can start with your talk.
Thank you. First of all, I would like to thank the organizers for arranging discussion on COVID in rural areas. And as Dr. Sanjeev Kumar very rightly said, that we can't just focus on what is happening in the cities. There are dire states that are developing in rural areas. So that discussion is important. What I'm trying to do is essentially discuss this COVID epidemic in the context of what is happening in terms of public health response in India. So instead of focusing on individual cases, what I'm going to do is let's see how we are doing in a context of public health system. So, and why we need to focus on rural India, because I'm paraphrasing Mahatma Gandhi here, is India is not Calcutta or Bombay. India still lives in 700,000 villages. So any discourse on India cannot discount rural India, because 66% of the India's population still lives in rural India. So what are the priorities of rural India? When we live in urban India, we have this fantasy notions about rural India that people there are sturdy, work hard, and so they're exposed to infections, so they will not get infections. They don't have chronic diseases. And a study done by us in 2011 and 13, we looked at causes of death in rural Gadchiroli, and it was an eye-opener. What we found was that stroke was the leading cause of death, and the infections are gradually declining. And if you combine, the non-communicable diseases versus infections, you see that non-communicable diseases have emerged as a leading cause of death, even in a very underdeveloped district like Gadchiroli. And there are several challenges to healthcare delivery in rural India. And what are those? So let's look at the vulnerabilities of rural population. So we know that elderly population is very susceptible to COVID. And what is the distribution of vulnerable elderly population in urban versus rural India? And you see that there is no difference in terms of elderly population. So it's about the same, 8.3% versus 8.4%. Then you look at distribution of people with high blood pressure. So in rural India, close to 25% of adults have high blood pressure, as against 33% in rural India. And diabetes, you can see some difference, but again, it's catching up fast in rural India. Look at healthcare resources that we have in rural India. So 66% of the population lives in rural India, but it only has about 40% of total healthcare workforce, which includes nurses and paramedical staff and doctors. So I call this 60-40 paradox, meaning that 60% population lives in rural India, but only has 40% of healthcare resources. And even the healthcare resources that we have are dispersed in rural areas because the villages are separated. Then we have shortfall of infrastructure and personnel in healthcare facilities. So you can see that there is 30% shortfall at the level of rural hospitals. There is 22% shortfall at the primary health centers, and there is 18% shortfall at the level of sub-centers. And then there are social factors which usually influence people's behavior. So, providing clinical care in a rural setting versus urban setting, what is different is the change, social factors. So, for example, early during the pandemic, people were fearful of COVID-19. So they had fear of media messages, and the fear was much larger than the lived experiences of no cases around. And that continues to be the case because, in rural India, people largely depend on lived experience. So if we are telling them that, COVID is a problem, but they don't see a lot of deaths around them, they're not going to listen to you that, COVID is seriously a problem. And there are a lot of perceptions such as, I will not get COVID-19 as I do a lot of physical work in the farms. And that perception is still there in rural India, which is proving to be a major hindrance. And on the top of that, there are like pan-India rumors. So this particular rumor was there that patients with diagnosed COVID are hospitalized and their kidneys are removed and dead bodies directly disposed of by the government. And that was sort of enforced by, in the first wave, that dead bodies were directly disposed of. And once you start this rumor, there is no end to it. I mean, I was surprised that this rumor was circulating also in rural Punjab. This was also in rural Chhattisgarh, and it's also there in rural Maharashtra. So when COVID-19 became a problem for us, we started anticipating that we will get COVID-19 in rural Gadchiroli. So the key thing that we did is first, let's understand what's the natural history. And we got the natural history from what happened in China, because at that time, there were no specific therapies available. So good thing about COVID-19 was that 85% of the cases will be either mild or asymptomatic. So that actually is a great thing from public health perspective, because you're not immediately going to have your hospitals flooded. And only about 15% needed hospitalization. So that was sort of a good news from COVID-19 perspective when it came early. Then from the available literature, we figured out, what is going to be the timeline of this infection. So we need to know. So, and this was wonderful review in the NEGM, and showed that, those who are going to be sick will get sick about 7 days after the infection. And those who are going to be critically ill will subsequently get sicker. So we had a clear idea of timeline. So for example, if the patient presents in first 5 days, we need to expect that things might worsen at a later time point. And so based on available resources, we created this simple diagram for our own understanding, is that we need to remember certain days. So day 0, day 7, day 10, day 15, and day 18. And so those who are going to have mild infection are going to have their peak of their symptoms by 7 days, and then they are gradually going to improve. Those who are going to have moderate infection might go a little longer, and then they are going to improve. Those who are going to have severe disease are going to have worsening that will start from day 7 to day 10, and then subsequently. So this provided us as to a general guideline as to how we are going to deal with patients. Then diagnostic facilities, as Dr. Ashish had mentioned, they're scarce in rural area. So we got some COVID-19 rapid antigen testing provided by the district administration, which actually was very helpful. And then we could set up a TrueNat RT-PCR facility here after getting NABL accreditation. My wife is a pathologist, and she helped us set this facility. So good thing was to get access to RT-PCR diagnosis. Then we focused on training of our hospital staff. So, first there was a lot of scare among hospital staff as to, what this infection is. So we trained them at search, as well as we got help from nurses in Delhi to actually tell them proper use of PPEs. And we actually really focused on this really hard, so that, when we are providing care, the staff should not get infected. And I can say that so far, none of our staffs have gotten infected. And the key thing of it was essentially using an N95, and on top of it, using another mask. So double masking was very important. Then what we did is we wanted to simplify COVID-19 management, because in rural area, you need to simplify things and have a minimalistic approach, as highlighted by Dr. Srikanth. So we categorize patient as mild, moderate, and severe just based on SpO2 at room air. And based on this, we designed our treatment strategy. So all the mild infections will not get anything other than paracetamol if needed. Moderate infection would get admitted, would get oxygen. They would get dexamethasone at 6 milligram daily IV or oral for a total of 10 days based on what has been shown in the recovery trial. And we give them heparin and proning. And severe cases, again, we start with oxygen supplementation, dexamethasone, and proning, and mechanical ventilation when needed. So we formulated a guideline for us so that the team had clarity as to what they're going to do. And we also understood that there is no cure for COVID-19. So whatever treatment is going to be there is going to be supportive. So early detection of moderate cases was an important strategy. So using pulse oximeter, and access to pulse oximeter is not easy in villages. So we trained community health workers to actually screen them. Providing oxygen was important, and as has been very clear in cities now that people are striving to get oxygen. So we use oxygen concentrators, which are not dependent. So we are not dependent on oxygen cylinders. Steroids, again, as already mentioned in the recovery trial, decreased the risk of death among those on invasive ventilation by 36% and those needing oxygen by 18%. So steroid was a good thing to have from public health standpoint because dexamethasone is very inexpensive. Remdesivir, there was some benefit in a CTT trial, as already discussed by Dr. Srikanth, and Solidarity trial showed no benefit, so we stopped using remdesivir. We use unfractionated heparin, 5,000 to 7,500 unit SC twice a day, based on moderate, if the patient has moderate or severe COVID. And we use antiplatelet agents, ecosprin, in those with mild disease, but they have other risk factors such as hypertension, diabetes, or obesity, and insulin where patients were diabetic. And we did not use hydroxychloroquine, favipiravir, azithromycin, doxycycline, or ivermectin at all. And so this is an example of a patient. The big challenge in rural area was to get them to come to hospital for admission. As I said, there was this pan-India rumor of patients' kidneys being removed. So this gentleman who had 10 days of fever and cough, had some shortness of breath, and was not willing for admission initially as he was scared of hospitalization. So, but then there were 3 deaths in his village. So then he could be persuaded to come and get admitted. And when he came, his oxygen saturation was 88% on room air. And all we did is we did the chest X-ray, which looked like this. We did some basic investigations and treated him with oxygen, dexamethasone, heparin, and he recovered and was discharged. And so far we have been, we have treated close to 85 patients, and we had 1 death only when the patient came very late and died within 15 minutes of arrival. The big issue being, late arrival of patient, as you've also seen in urban areas. Most of the patient could be managed on the treatment algorithm that we have designed. And so we also were pleasantly surprised to see the response of the government healthcare system in rural Gadchiroli. They did set up care for COVID-19 at a separate facility at the district level. There was isolation centers at the taluka level, and free food, testing, and medicines were provided to all patients. And as far as fatality of COVID-19 cases in rural India is concerned, there was some hypothesis that Indians are somehow protected from COVID-19 mortality. And in rural India, since patients are exposed to a lot of infection and probably some coronaviruses, then mortality could be low. And there's very little data on rural India, and I had to really sort of mine for these. And there was one piece of data that was published by the Hindu, and there was no other scientific body published this. The Hindu published this. And there was a clear gradient in terms of mortality from urban to rural areas. So as you can see, and that mortality also improved as hospitals and doctors started, they got their treatment algorithms corrected. So urban mortality came down, case fatality came down to under 3%, and rural India it remained about 1%, and that was also true in Gadchiroli. So between March 2020 to March 2021, for about 13 months, there were total documented cases were 10,000. And documented deaths were about 100. So it gives you a case fatality of about 1%. So we need to keep in mind that in Gadchiroli, this being a very rural tribal district, there are going to be a lot of undocumented cases, and you just have to figure out a factor by which you need to correct this. But it could be, double the cases could be undocumented. So case fatality was 1%, but things have changed in April. So we have added another 10,000 cases just to show how rapidly things are worsening in Gadchiroli. The documented deaths have gone up from 100 during this entire 1 year period to 300 in just 1 month. So case fatality has gone up to 3%, and I'm afraid that it is going to go up further until we reach a peak and then things start to improve. And then, so as COVID-19 not only has affected, we can't only talk about care of COVID-19, but it has affected the healthcare system, ability to deliver care for other ailments as well. And so we need to see in rural tribal areas, government healthcare system remains the key healthcare delivery system. So what has happened to healthcare delivery in rural India? So I got this data from National Health Mission, and we can see that I'm comparing data from January 19 with January 20 and so on and so forth. So 2019 versus 2020. Has only data until June 2020. So you can see that the care was pretty okay. And then we had this lockdown where outpatient consultations for hypertension went down by a factor of about 20%. And then it started gradually improving. And now it's going to get worse again with the second wave hitting in. Inpatient admission, so hospitalization was significantly affected. You can see compared between January, February, March, things were quite okay. And then April, they started going down. May and June were significantly affected. So everywhere there were almost 50% reduction in outpatient consultations as well as inpatient admissions in rural India. So the larger question we need to ask pertaining to what is happening in rural India is, will this lack of care lead to increased deaths from all causes other than COVID? Will this lack of care lead to increased disability? And I'm aware of several patients who could not go to Nagpur for dialysis. They were on dialysis and they were so scared to go that they did not go for dialysis and the patient died. There are a lot of patients who cannot be for further care. So we have to see that not only people are going to die from COVID-19, but they're also going to die from not getting, hyperacute care during these settings. And we'll have to wait for some time until we get this data. And the question would be, what will be the long-term impact of this epidemic on population health? So this is a big question that we need to ponder. And the key observations or learnings where government healthcare services responded better than at least my expectation in rural Gadchiroli. And by and large in rural area, they were the key responders to the epidemic. Hospital-based healthcare services were significantly affected. Community-based care closer to communities was less affected. So if you look at data in terms of, ANC, antenatal care provided by ASHAs, they were not that significantly affected. So that just tells you, how important it is to decentralize the care. Changing public behavior related to use of masks was extremely hard, but that I cannot only blame rural India. That was the case in the US and many other developed countries as well. So simple behavioral change in public will take very, very long time. And, COVID was no exception. The sad thing was there was a huge suspicion about care provided by government healthcare facilities. And that's why, again, as I said, there were rumors going on and people were extremely reluctant to go and get admitted. So there were instances where villagers actually attacked the screening teams because of the fear that the screening team will diagnose and take them to hospital and they might die there. And patients were screaming that, we would prefer dying at home rather than dying in the hospital where they can't do the final rites. So essentially, COVID-19 has served as a stress test for our health and social system. So we need to not only think about acute hospital care, which as a trained clinician, we are only focused largely on, but now this is the time to actually, sort of zoom out and reflect as to what we need to do to improve, in general, healthcare in India. And decentralized healthcare, which is provided closer to the communities, is a way to go. So, as much as possible, we should, for example, hypertension and diabetes care. Patients who are taking their treatment from primary healthcare centers, they could continue to get their medication. So that just tells you that the closer the care to the community, the less disruption it will have. Then we need to actually explore use of technology. So telecare and point of care diagnostics are something that we need to actually invest in and start improving care, because telecare, especially in rural areas, if they have access to smartphone, then actually it's quite helpful for patients because it avoids the need for travel, need for expenditure. And if they're chronic and under chronic care, the medication can just be continued by making some arrangements. Strengthening the surveillance mechanism, data collection, and real-time monitoring was extremely important. And systems like CoWIN and other monitoring systems, like all the data on COVID diagnosis has to be uploaded on ICMR portal. That actually helped us to track this epidemic in a much better way rather than if you just had a paper-based system. So there are some pluses from this pandemic as well. We need to correct rural healthcare shortfalls and in terms of infrastructure, in terms of human resource, and Dr. Sanjeev Kumar already alluded to this. And key thing is to reduce out-of-pocket spending by making rapid strides towards achieving universal healthcare. In India, 70% of healthcare is still provided by the private sector. And that means that only those who can afford it will try and get it, and those who cannot afford will suffer a lot of times. So this is something that we need to really push hard as a nation. And so the key thing now would be to prevent third wave, and Dr. Srikanth has already alluded to it, that there is prediction based on modeling. And so the way out of this third wave would be vaccination. And the thing that is happening in rural India now is, there is availability of vaccine is an issue. So earlier people were very scared. They did not want to get vaccinated because of a lot of rumors, again, going regarding, people dying after getting vaccine or having fever. So, there is a concern that they might lose a wage for a day if they don't, if they get vaccinated. So that's a big concern for them, because if they're losing a wage for a day, that's a big cost for them. So there is also a lot of hesitancy in rural India, and I think physicians who practice in cities need to now come out and give messages to people, because the rural area looks up to people in urban centers, and so we need to design locally suited messages so that they reach people and people come ahead and get vaccinated, and also make sure that vaccines are available in rural India. So I have a friend who works in rural area of Washim, and there was people were not coming when the vaccines were available, and now people are queuing up in hundreds, and vaccines are not available. So that is something that we have to really tackle now. So to end, COVID-19 is a once in a century, hopefully, a situation which puts spotlight on health and to some extent on rural health. In general, again, this is played out as an urban phenomenon in media and also in people's minds. So that is not the case. So I'm saying that to some extent, people will wake up to the realities of rural health. And we have this opportunity to improve rural healthcare, and we should not squander. And we have had to fight this pandemic at times with personal losses, and a lot of physicians, died providing care, and our kids and kins were lost in this fight. So let's convert this learning into enduring change in healthcare in India. And with that note, I will stop my presentation. Thank you.
Thank you, Dr. Yogeshwar. You are doing a fantastic work in the rural Gadchiroli area. And at this point of time, we wish you all the very best and hope you continue to do your noble work in helping the villagers and the rural folks who have very limited resources. And with very limited resources, you are doing a wonderful job, and we wish you all the best. And I do agree with you that we urbanites have some responsibility to help you out in some form or the other. So if you have any help to be given to you or to your patients, at least at my personal level, I'm ready to help you. You can just communicate to me anytime, 24 hours, 24/7, and 365 days of the year.
Thank you. Thank you so much.
Yogesh, can I ask one question, please?
Please.
Yeah. So you mentioned about the vaccine hesitancy in rural India. I think it's everywhere, to be honest, and there are so many anti-vaccine campaign going in the West. So I think I'm just wondering whether to change the situation, whether you could perhaps use the religious leaders or community leaders who can convince them, because that's what is, because here in UK there was a lot of hesitancy in especially in the Muslim community, ethnic minorities, and what the government has done, and rightly so, they have used all the imams and all the religious leaders, and now it's getting better. So I think we need to find some new approaches to that. I don't know whether you could do the stuff there as well.
Yeah, no, I think that's a wonderful idea. And in terms of resources, whatever resources we can get, I mean, the religious leaders are there, politicians, senior doctors who are very well reputed. They need to come out and actually sort of message to the community to, for this behavioral change. So it's, in the West, the reasons for hesitancy is different. The movement is much more organized. In India, it's not organized, but it's still very rampant.
Yeah, exactly. Thank you.
Dr. Yogesh, it was a wonderful talk and insight into rural health sector. In spite of all the shortcomings, you are doing a wonderful work. And I think by this, we should learn many things. And most importantly, to promote vaccination is the key role to prevent third wave, as said by Shrikant sir. So we need to motivate people, because I have seen many people are very reluctant. We need to convince even our patients. Pregnant patients are hesitant because there are no guidelines whether they can be vaccinated, Indian guidelines I should say. And even lactating mothers, now I'm trying to promote in them, because anyways what is going to happen is the antibodies will be transferred from mother to baby through the breast milk, which will be good. So to promote vaccination should be the motto to prevent the disaster of third wave, is what I feel. Jai Deshmukh sir, your opinion on this?
Yeah, I think you are absolutely right. What I'll just tell you one simple information, real life story. I have a junior doctor working with me. He is having two children, one 5 years and one about 4 or 5 months old baby. She's breastfeeding the baby, obviously, and she comes to the job. She's exposed to 50 COVID patients every day because I see them. She's my assistant. I've been telling her that this is very risky for you. Why don't you have a vaccine? So she went to 1 or 2 vaccination centers,
and
Hmm.
they refused. They said that as you are lactating, we cannot give you. So I told her to go to the third, and when she went to the third, she told
Hmm.
them that I have no children, I am not married, and now you give me the vaccine. So ultimately, she got the vaccine over there, and now I'm happy about it because now she'll be due for the second vaccine because there's a lot of ignorance even
Yeah.
for the caregivers, and now she's happy. So I think this needs to be taken care of. That these people who are lactating and those who are post delivery are
Yeah.
more vulnerable because the immunity is
Yeah.
not normal, and therefore, and then when they are going to be exposed to 50 COVID patients every day in spite of double mask, there's always small lurking this thing, sort of a fear in their mind. So I think this is how we need to spread the message. Yeah.
Yeah, yeah, rightly said, sir. And one more thing I would like to highlight here, that many patients I came across that early pregnancy, they opt for termination because they are very much afraid
Scared.
of continuing the pregnancy. It is very difficult to convince them.
I think,
do agree with you.
sorry, can I come in for this? Yeah. Ragini, I think what we need to do basically is your professional bodies like your College of
Yeah.
Obstetrics and this thing, they should come up with some guidance because there's some confusion amongst the doctors as well whether to give vaccine or which one, and all these questions, and they have been addressed. So if you see the CDC guidelines, public health guidelines, you need to have some proper national guidelines, or at least you can have in
Yeah.
Nagpur as well, and you can address those issues because yes, there are loads of uncertainties, and definitely you don't need to terminate the pregnancy. There's no evidence for that.
Yeah.
There's no evidence whether the COVID would affect in any way. Vaccine wise, I mentioned about in UK,
Yeah.
they are suggesting Pfizer vaccine because the evidence is for
Hmm.
that, but they don't say that you can't give AstraZeneca or Oxford vaccine. You can give that, like your Covishield, you can give that because the risk of getting COVID in a pregnant patient is higher than not giving the vaccine. So effects of vaccination. So I would suggest that, I mean, this is my suggestion, that you come up with some guidance, and so that all your members of your society should have some similar opinion and similar recommendation, and they can counsel the patient about this thing. Can I mention one thing about this vaccination? I think Covishield is being used in India quite.
Yeah.
I mean, that's the only Covaxin and Covishield. So what I'm sure you must have seen these reports of cavernous sinus thrombosis and vaccine-induced thrombotic thrombocytopenia. Although the incidence is very, very small, so what we have got is 6 cases per million, which is nothing. So if you compare those things with your normal problem with the COVID infection, it's nothing. But at least we need to be mindful of this side effects and just to observe. Last week we had one patient, a young girl with 31-year-old with proper cavernous sinus thrombosis.
Okay.
So so the current recommendation here in UK is they are trying to avoid giving Covishield or Oxford vaccine to younger patients. But in India, we don't have options. We can't have Pfizer vaccine there. So it is important, and you just need to be clear that the risk is very, very small. So 4 in a million, 4 or 6 in million is nothing. And that needs to be highlighted as well.
Okay. Yeah. Thank you. Deshmukh sir, please.
Have been very well covered. And particularly, I would like to say again one more small thing, that in pregnancy, the D-dimer levels gradually go up in each trimester.
Yeah.
Okay. And you see, the point is that many of our OPD patients come to us even in the ANC period with all the reports, even we have not ever asked them for CBC, interleukin 6, D-dimer, CRP, ferritin, everything they come up. Now they say what to be done. So as physicians, we should realize that D-dimer levels are physiologically known to increase in certain subset of people even during pregnancy, and the levels gradually go up from first to second to third trimester. Second point is in elderly people, the D-dimer levels are always very high. So we should not jump to a conclusion and start giving heparin left, right, and center to all patients with borderline or slightly increased D-dimer. We need to apply our clinical acumen and try to assess
that which patient is at a high risk of vasculopathy, and then take care. But what my own experience is that those patients who have a significant CT score of more than say 20, those patients who have very high IL-6, those people who have more than 60 of CRP levels, those patients who have progressive increase in their oxygen requirement, and those patients, these are the guys who are likely to have vasculopathy. And we as physicians need to be very careful about that. We have seen patients that those who have surgical emphysema or pneumothorax are those who are more prone to have this vasculopathy also. We have seen about 5 to 6 patients with intraatrial and intraventricular thrombosis on echocardiography, and which is just moving around. Many patients have been having to have arterial thrombosis in femoral artery, popliteal artery, and all that. And then, irrespective of what you do, you give them low molecular heparin or you give them bolus of heparin and then hourly heparin, it has not worked. So a combination of pneumothorax, surgical emphysema, vasculopathy, peripheral artery disease, peripheral arterial thrombosis becomes a very, very difficult proposition, and these patients have high mortality. So come what may, I think the 2 to 3% mortality group might be coming into this.
Yes, sir. Rightly said. So it was really indeed an informative talk from all the aspects, from urban, rural, every sector, and our experts commented on needed questions and necessary things to be done in general and pregnant patients. So thank you very much, Jai Deshmukh sir, Anurag Bahekar sir, and all the faculties and all the audience who were patiently hearing all the speakers in spite of some technical problems. Anurag Bahekar sir, do you want to comment on Dr. Yogeshwar sir's talk?
I think he is not logged in.
Okay. So now I hand over the mic to our secretary, Dr. Sachin Gathe, for the further proceedings.
Thank you, Ragini ma'am. So on behalf of IMA Nagpur, President Dr. Sanjay Devtare and myself, Dr. Sachin Gathe, Secretary IMA Nagpur, I am very much thankful to Dr. Ashish Sato and our Divisional Commissioner, Dr. Sanjeev Kumar, our international faculty, Dr. Shrikant Ambadkar, our another speaker from a rural background, from a very prestigious NGO search, Gadchiroli, Dr. Yogeshwar Kalkonde. I am also thankful for giving time by our expert, Dr. Jai Deshmukh, Dr. Anurag Bahekar, and I'm also thankful to MMC, Maharashtra Medical Counseling, for granting one credit point for this CME, and observer, Dr. Archana Kothari, and not but the least, moderator Ragini Manli, and behind the curtain, Dr. Shehna Chimtanola. She has taken all the efforts to materialize this CME. I am thankful to all the audience and the DG who has given us technical.
Sorry to interrupt, Dr. Sachin. Can I just take some time?
Yes.
Yeah, actually, I just forgot to announce the e-mementos are there. So kindly you cover about e-mementos. Just add to your talk.
Yeah. So yes, the CME is not ended without memento. Yes, we are our international, our national speakers, our experts, our moderator. They must deserve this memento. But as we are not physical, so please accept our memento. It will be delivered to you by email digitally. Please accept that token of appreciation. I'm thankful to all. I'm thankful to DG Shield, Dipen, and his team for giving us a technical help. Thank you on behalf of IMA Nagpur. Good day.
Okay. Thanks, Sanju. Thanks, Ragini. Thank you, Yogesh and Ashish. Thank you.
Thank you, Dr. Shrikant. It was nice listening to you.
Thank you to all.
Thank you all.
Thank you.
Dr.
We are-
Sachin, let the digital people display the e-mementos so that it can
Yeah,
be
yes,
seen by
yes,
all.
yes, yes. And Piyush or Chirag, please email this e-memento to all the speakers, experts, and our chief guest also.
Sure, sir.
So,
Done, sir.
yeah.
So,
So it's all for the day. Okay. Enjoy your Sunday. Thank you. Thank you all.
thank you,
Thank
sir.
you,
We
everyone.
are officially ending the webinar here.
Yeah,
Thank you.
please.